Well, it's a thrill to be here again this year and welcome everybody to Cleveland. It's been an exciting couple years here. Last year we were this close to winning the World Series. I'm sure there's a few Cubs fans out there. All right, she fails. Camille, make sure this woman fails. Anyhow, I have all these different things. Anyhow, so it's been an exciting year. The Republican National Convention was here last summer, and et cetera. So we've had a lot of exciting things happen in Cleveland. But this is the most important thing. The four cutest kids in Ohio, that's Kayla, Seth, Nathan, and Eva. And what's best about having grandchildren? You can give them back, exactly. Whoever said that, they pass. Whoever says that, they pass automatically. So very good. So we're going to talk about orthopedic emergencies, and certainly I'm not an orthopedic surgeon, and none of us in this room are going to be orthopedic surgeons at the end of this half-hour talk. We're just going to review the highlights. This is the headline news of injuries that we see in the emergency department. As I said, he says I work at Children's Hospital in Pittsburgh, and you might see in your office, or you might be involved with, and we're going to talk about a little bit how to take care of them. So we're going to talk about the different types of fractures, and we're going to look at some radiographs of bones and injuries and highlight subtle fractures, because big fractures are easy to spot. So we're going to highlight subtle fractures. That's more fun to pick up on those. So why are kids' bones different? I mean, why do we have to even be concerned compared to adults? And this might be a kind of test question. We have to remember that the physis is the ends of the long bones. It's under compressive forces, and it's radiolucent. And in the same picture, we see an apophysis. It's the center of ossification and a bony prominence. It's usually under traction forces. Now, the physis is relatively weak, and so it's going to fracture before a sprain, which is a tear or stretching of a ligament, is going to occur. So when you have a 6-year-old, there's no such thing as a sprained ankle or a sprained wrist. They're going to have a fracture or a contusion. Now, when you have a 14, 15-year-old who the growth plates are closed or they're almost completely closed, then certainly you can have a sprain at that time. What's another difference is the periosteum in kids is thicker, it's stronger, it forms a quicker callus. So kids will be out of pain a little bit quicker than adults, and also because we have a real thick periosteum, it'll prevent comminuted fractures that you see in adults. So this is a nice example. On one x-ray, we have three different things. We have obviously a midshaft of the clavicle fracture, and that's the most common spot that's going to occur. You have a normal coracoid apophysis, that's not a fracture, and you have a normal humeral head epiphysis, or physis, I mean. So, and here's the epiphysis. So you have three different things on the same x-ray at the same time. That's pretty interesting. So why are kids' bones different? They're less dense, they're more porous, they're going to fail with compressive forces when they fall on an outstretched hand, the so-called fouche, or they land on their heel. The forces are transmitted up through the bone, and you're going to get certain types of fractures we're going to talk about. And remodeling for children is more common at the fracture site, so our orthopedic colleagues can accept a little bit of angulation at the fracture site, at the growth area, as compared to farther away, because we know it's going to remodel and it's going to do well. So we always want to find out what the mechanism of injury is. Was it longitudinal force? Like I said, did they fall on an outstretched hand? Did they land on their heel from a height? Or was there rotational forces? Did it get their foot caught in something and did it twist? So you have rotational forces. My experience has been, and almost always, direct blows, unless it's a linear kind of thing where someone gets hit by a linear bat or something like that. Direct flows, when they fall under their kneecap, they usually do not have a fracture. That's not the kind of injury that causes a fracture. We all know our normal developmental milestones. That was drummed into me as a resident. I'm sure it was all drummed into all of you also. We know that the child at 9 months of age has a parachute reflex, and so we know that before that, they may not be able to protect themselves, but after that, they might be able to do it. So we always have to keep non-accidental trauma in mind. We're going to talk about it. I know Dr. Walsh just talked about it. When you think that there's a problem with one area of the extremity, I always say examine the other areas first, so you don't lose the child's confidence right away. If you're palpating along the length of the bone, you're not sure where there might be a problem, listen for cry increase, or listen or watch when elevate their shoulders. And always want to record their neurovascular motor status. If you're splinting it and sending it to your orthopedic colleague, before you send it, you may want to record their neurovascular motor status to make sure that's intact. So when you're looking at x-rays, and everybody has now the x-ray capabilities, it's so much easier than it was many years ago when we had to look at everything ourselves. Our radiology colleagues are usually available 24 hours a day with Nighthawk or whatever. But lateral views are always the key view to look at. If you haven't looked at the lateral view closely, you're going to see why it's important. You're going to miss subtle buccal fractures. So try and obtain specific views. We're going to show you several examples now of why, if you don't obtain the specific view, if you get a whole large view, you might miss a very subtle fracture. So that's where the most detail, that's where the beam is centered. So remember that. So again, this was not taken by myself. This was done by somebody else. They ordered an extremity view, and it was read as perfectly normal. All right, and they came back the next day, and I examined them, and we were concerned about the elbow. And sure enough, you can see the posterior fat pad, anterior fat pad's pushed away, and has a little fracture here. This is the same exact child that was read as normal the day before, because you want to get specific views. Here's another example of a long bone where they didn't get specific views, and it was almost read as normal. Someone almost missed it, and if you get specific views, you can see right here there's a little baby buccal fracture there. There's a little outpouching there. If you go back a second, you can see it's very easy to miss. You want to get specific views as many times as possible. Again, here's another example. As a 7-year-old girl, she was tendered the MCP of a ring finger. If you look at the proximal phalanx of the ring finger, it's smooth. There's no cortical disruption. It looks perfectly normal. But now we get a more specific view of that finger and a lateral view, and you can see that there's a buccal fracture. The bone comes down. It's nice and smooth, and all of a sudden makes a sharp angulation. So that's a little buccal fracture of the ring finger of the proximal phalanx. So you want to get specific views, and you want to get where the beam is centered. Comparison views are sometimes very helpful, especially when you're dealing with the elbow. You remember there are 6 ossification centers, and there's a couple mnemonics to remember it. We always forget them. But if you're not sure exactly what's going on with the other elbow, get a comparison view. But if you look at this one quite closely, you think everything's normal. But if you had a comparison view, you'd realize that this is the medial epicondyle that belongs up here. It's been pulled down. So if you're not sure, especially on elbows, we frequently get a comparison view of the elbow to take a look at the ossification centers, and you should get in the habit of that. This was a child who fell from a height, and the attending radiologist read this as a normal finding off of the patella. They fell from a height. And again, remember, the only thing you got to remember from physics, we all remember physics, and then high school and college, but the only thing I remember is force equals mass times acceleration. And he had a lot of acceleration because he fell from a height. And I said, I don't think this is normal. I think this is a problem here. We get a comparison view, and you can see that little avulsion wasn't there. And of course, the radiology colleagues are able to change the dictation. And the emergency department in our offices weren't able to change things once we've made the diagnosis and sent them on their way. So be cautious about that. When you're describing fractures to your orthopedic colleagues, you always want to talk in their lingo as much as possible, so they'll help you out as much as possible. And when you're looking at displacement, as you see here, you want to describe the distal part compared to the proximal part. So there's this kid's wrist, and it looks okay on the AP view, but if you look at the lateral, you can see the radial epiphysis is about 50% dorsally displaced. So you would describe that accurately to your orthopedic colleague, and they would help you out or tell you what we're going to need to do. So question number 1, which fracture is almost never seen in pediatrics, but one usually seen in adults? A buccal fracture, a spiral fracture, a bend fracture, a comminuted fracture, a green stick fracture? All right, old Cleveland Cavalier nemesis, Michael Jordan. I wish I could. And the answer is, yeah, that's correct. Comminuted fractures rarely occur in children. Remember, we talked about that thick periosteum that doesn't allow the splintering of the bone, almost never. So it's comminuted fractures. You can get buccal fractures. You can get green stick fractures. You can see spiral fractures. Yeah, we always want to be concerned about spiral fractures that are not explained, but we see spiral fractures in kids that get their feet twisted or get their legs twisted, and can be seen when there's rotational forces, and so-called toddler's fractures. So that's the answer to that, comminuted fracture. So the question number 2 is, all of these are true about buccal fractures except So again, as Dr. Walsh said, read the question carefully because some of the questions are going to be in the positive and some of them are going to be in the negative. All right. So they occur when longitudinal forces are applied. Most common place in the diaphysis of the bone. They're stable. They're best seen on lateral view, and they can be diagnosed with a sudden sharp angle change. I just gave you a couple of those answers before. And that's a buck, not a buckle, for those. All right. See what you all got. And they're seen in the metaphysis of the bone, not the diaphysis of the bone, because that's the metaphysis of the bone is the area that's most porous and less dense, and that's where you're going to see buccal fractures. So let's talk a little bit about buccal fractures. They're also known as a torus fracture, sort of the bulging out. You see of those, the columns in the Greek architecture, the pillars. Those are they're torus. The other kind of fracture is a bow bend or plastic deformation fracture, green stick fractures, and complete fractures you can see in children, but they're usually more commonly seen in adults. So again, this is very easy to see. You can all see the buccal fracture. They're occurring in the metaphysis of the bone, not the diaphysis of the bone. It's when there's longitudinal forces along the length of the bone. There's no swelling. There's no ecchymosis. These are stable fractures. So you can splint them. You may or may not even want to have your orthopedic colleagues see them, and they're going to do just fine. They don't displace. Buccal fractures do just fine. So here's another example. If you look real closely, you get a hint by looking at the AP view that there's a little bit of irregularity here. It's not as smooth as you would like to see. Normally, long bones flare out real smoothly. Remember, anybody used to wear bell-bottom pants like I did in the early 70s? No one remembers them. Anyhow, bell-bottom pants flare out real smoothly, and that's what they should do here. But there's a little bit of irregularity here. And if you look at the lateral view, and you can even forget the radiologist put the arrow there, you can see there's that sudden sharp angulation. So when you see sudden sharp angulation, that is probably a buccal fracture, especially in the metaphysis. Here's another view of an AP view. Does anybody see anything? No, not at all. But now you look at the lateral view, and sure enough, there's that sharp, sudden angulation. That's a buccal fracture till proven otherwise, and you want to treat it as such. So this is another example. A child fell, and instead of landing on an outstretched hand, they sort of landed and with their fist directly down onto the hard object. And sure enough, if you look here, you don't see anything on the AP view, but if you look at the lateral view, right here, there's a buccal fracture of one of the metacarpals. So again, there's longitudinal forces. When you get that history, or you suspect that that's the history, there you always want to think about a buccal fracture. Okay, the ball hit the child at the end of the fingers. When I grew up, we used to call it a stoved finger. Okay, there's no word in the medical dictionary of a stove, but everyone uses that. And if you look real carefully here, this is all nice and smooth, this is all nice and smooth, but there's sharp angulation here, and there's sharp angulation here. So at the long and ring finger, at the proximal phalanxes, that's where you're going to see buccal fractures when something hits a child at the end of the long bones and has longitudinal force. So here's another example. This is a little child who fell, landed on their fingers, and if you look real closely, there's a buccal fracture here and a buccal fracture there. You don't see it very well on the AP view. So again, if you miss a buccal fracture, is it any big deal? No, but again, I know in the emergency department, and for those in the offices or clinics or where urgent care center, wherever you work, you don't want to miss anything. We all pride ourselves in catching everything all the time, obviously. So again, you want to get specific views. You can imagine, here's a buccal fracture of the distal femur. A child landed from a height and landed on their heel, and the forces were transmitted all the way up to the femur. But if you got a femur view, you could easily see how you could miss that. Okay, easily you can see how to miss that. Here's a tiny tibial fracture. Again, it's down here, but you can see that you could easily miss that if you weren't looking, and it's better to get specific views. Okay, and here's another example of a tiny little buccal fracture right here. This is a limping child who comes in. You're not sure. You palpate all along the length of the bone. You're not sure where they're tender, and sure enough, you think that they're tender around the knee area. You get films, and sure enough, the kid's got a little buccal fracture right there. It's hard. It's nice to see there. This is very interesting. This young man was playing with his friend, and part of the latch on his belt flipped up, fractured a zygoma, and we called that a buccal fracture also. I told that to the orthopedic doctors. They didn't get it. Okay. I had to explain it to them. Okay. So bow and bend fractures, these are a lot of fun. They're not very common, but when you find one, it's really very cool to find it, okay? You usually see the ulna and the fibula. You can see it in the radius. You can see it in the tibia. It's called plastic deformation, where the bone bends, but it doesn't fracture all the way through. So there's no true fracture, and since there's no true fracture, there's no swelling, there's no ecchymosis, and this is really where you're going to need comparison views. So if you look at this young lady sitting on her father's lap, you sort of have a human comparison here. If you look just at her arm, it doesn't look so bad next to the father's arm there, but now you have a human comparison, and this is nice and straight, and you get the feeling that there's a bit of a bend here, and sure enough, if you look at this is where you need forearm views. You don't want to get specific views, and sure enough, this kid had a plastic deformation along the length of the forearm, so that's cool. This is a 4-year-old girl who fell from her bike on an outstretched hand. I told the mother, don't worry, it's going to be a buccal fracture. And she's, how do you know? I said, oh, I'm so smart, I don't make them. No, I said, well, that's probably what it's going to be. And sure enough, we looked, and there's no buccal fracture here at all. But what do you see? And if you look real closely at the comparison view, it's nice and straight, okay? And here there's a bow fracture of the distal radius pointing anteriorly. So that's a bow fracture. And if you look at the lateral view, you can see right here that the radius and ulna don't line up over top of each other, and they should. So this was a bow fracture of the distal radius. Here's an elbow, looks very nice on the lateral view, and you look at the AP view, that looks nice, but now on the oblique view, you get the feeling that the ulna has a bow fracture right there. So that's what's interesting. This is a 13-year-old male who came in, and his chief complaint was sort of like the chief complaint of the Cleveland Browns quarterbacks. His chief complaint was, it's hard to throw a football, okay? There was no swelling, there's no ecchymosis, and if you look real closely, okay, you notice that the distal ulna is not parallel to the distal radius on the ulna, on lateral. And when you get a true lateral, the two should be lining up right over top of each other. So we weren't sure, and we got a comparison view, and you get the comparison view, and they line up real nicely. So this kid had a bow fracture of the distal ulna, and something to recognize. You can splint, and we can send it to our orthopedic colleagues. Green stick fractures are really bow fractures that now have gone past the bending limits, okay, and there's a fracture on the tension side, and the compression side will bend. So really based on the angulation and how far it is away from our growth area, our orthopedic colleagues are going to have to decide whether to reduce it or not. In our emergency department, we use ketamine sedation quite often. Last year we had one night 13 fractures in one night that we needed sedation for. So that's how we take care of that. Very interesting here, you see a green stick fracture of the clavicle, and this young lady was a gymnast. Anybody have their daughters in gymnastics or sons in gymnastics? We see more gymnastics injuries. But sure enough, that's what she was complaining of. And when we get a picture here, we see, oh my gosh, she had an impact, sort of a buccal fracture of her proximal humerus also. She wasn't complaining of this. This is what bothered her. And what was her major question? When can I go back and play? Okay, these gymnastic people are very driven. Anyhow, complete fractures can occur, but unexplained spiral fractures, especially in the humerus or child abuse, still proven otherwise. So question number 3, what's the most common type of growth plate injury? Type 1, 2, 3, 4, or 5? Excuse me. That's my son and I back in '97, and maybe this year we'll be over the hump this year. We don't know. All right, so the answer is 2. Salter-Harris 2 comprise 85 to 90% of all growth plate injuries. So if you get a test question on that, I can't guarantee it's not 100%, but if you forget everything else, remember Salter-Harris type 2, and you have at least a 90%, if you forget everything else, you'll be at least a 90% chance of being right. Not 100, so don't quote me on it. So anytime there's joint pain or swelling at a joint, it's probably a growth plate injury. Type 1 involves the physis, there's widening. Type 2 is really the most common, as we said, and a lot of people think that type 1 is, most of the type 1s are type 2s anyhow, and you can't see the little metaphyseal chip. Type 2 is the most common. There's a fracture extending into the metaphysis. Type 3 is through the epiphysis. 4 is in the metaphysis and the epiphysis. Very uncommon. And type 5 was first described by Salter and Harris, but it's really in theory only. No one's ever seen it clinically, so you can forget about that. So here's an example. Here's a type 1. The physis is widened. Type 2, it's dorsally displaced, and here's that little metaphyseal chip. Type 3 is into the epiphysis, and type 4 is through both of them. And this is an example where you better check all the views when you're looking at a film. So you look at this one and everything on the ankle looks pretty well, but now you look at the lateral view. He's got a very nice extensive Salter II fracture posteriorly, so you want to make sure you look at all the views. This is a great story that I tell all the time, and this was a young man who was 6 years old who already weighed 50 kilos. So again, force equals mass times acceleration. So he was on a bicycle, so he had more mass than he should have for his growth area, and he had more acceleration because he was on a bicycle. And landed on his shoulder. His head of his humerus, his head of his humerus was completely knocked off. And I was working somewhere not far from here, and I called the orthopedic surgeon at another children's hospital located in Cleveland with some color in its name. And I talked to the orthopedic surgeon. He said, "Don't worry, just put him in a sling. We'll see him next Tuesday in clinic." I said, "Well, let me go through it again." And we went through it again. He got very testy with me. I said, "Just send him to the clinic. We'll see him next Tuesday." I said, "Well, then we're going to have to send him somewhere else." So he said, "So fine, send him to the ER." Not only did they operate him the next day, they operated him 2 days later. He got 2 operations the next day. Let's see a show of hands. You can push your button. How many think that he called and apologized to me? I see, I guess no. All right, so they always want to act in the best interest of the patient and describe it to them as accurately as possible, and hopefully our orthopedic colleagues will help us out. So again, you can have subtle growth plate fractures. As you see here, it's widened dorsally and ventrally it's not. So this is a growth plate injury. If they're tender there's pain and at a joint area, it's a growth plate injury till proven otherwise. Here's a nice example of where 2 + 3 = 4. I know it's a little bit of crazy math here, but here if you look at this one, this would be a Salter III. It's down through the epiphysis, and if you look, if you can forget the fibular fracture, this is a girl who fell off a bicycle. You can see here on the posterior, on the lateral aspect posterior, she has a Salter II here. So this is a 2, and it goes through, and it's a 3. So 2 + 3 = 4. This was a Salter IV fracture. And but you got to look at both views to be able to make the diagnosis. This was very interesting. And again, I'm not railing against gymnastics because my daughter did gymnastics until she fractured her elbow severely, and I love to watch gymnastics. But this is a little girl who was doing gymnastics and all of a sudden had some hip pain, and sure enough, it was in the inner aspect of her thigh, and she had a tiny little avulsion. We sent her home with crutches and some pain meds, and she did perfectly fine. And this was a child who's throwing a curveball, and if you all look, his growth plates are still open here. And for those of you who know a little bit about baseball, the kids below puberty, until they've finished puberty, shouldn't be throwing curveballs because of all the torque on the elbow. And sure enough, so I said to the parents, the coach should be told he shouldn't be throwing a curveball. Guess who the coach was? The father. He looked at me and says, "Well, I'm the coach." I said, "Oh. I'll put my other shoe in my mouth." So I mean, but the kids before finished puberty boys shouldn't be throwing curveballs. Okay. All right, so a 2-year-old girl was grabbed by her older sibling. She's crying, not using her left arm. This one, what do you do next? Order an x-ray of the entire arm, order x-ray of the elbow, hyperpronate the arm, supinate and extend the arm, or consult an orthopedist. That's my favorite girl, and she's now an assistant cross-country coach in Philadelphia, for those of you from Philadelphia, College of the Sciences. So anyhow, the easiest way to reduce the nursemaid's elbow is to fully hyperpronate the arm, okay? And the easiest way to do it to remember is thumb up, okay, the thumb down. Thumb up, take the child's hand, shake the hand, thumb up, the thumb down. Alternatively, the way I did it for many years until I learned this way is you can fully supinate the arm and then flex the arm, not extend it. So the easiest way is to hold the child like this and hyperpronate, thumb up, the thumb down, and it pops in almost all the time. My best story of that is about 4 years ago when my granddaughter Eva, who's now 9, who was 5 years old, she was 4 years old at the time, and I was downstairs in Thanksgiving, and all of a sudden I hear this screaming upstairs, and my beautiful daughter was twirling my granddaughter around, and all of a sudden she's screaming, not using her arm, and I sat him down on the bed, popped it right in, and it's got to be the fastest nursemaid's elbow reduction in the history of mankind. It was like within 1 minute I popped it right back in. So We always talk about that. So it's a common, it occurs more in girls than boys. Why does it occur more in girls than boys? Because of the carrying angle of the female elbow. It's a little bit different. It's more common in left arms because most of us are right-handed and we grab the kids with our dominant right arm. And I've seen it can occur between 4 months and 7 years, but I saw a 2-month-old child who was sitting in a sort of a walker and the older sibling grabbed him. And I saw an 8.5-year-old girl once that had a nursemaid's elbow. So it can occur at any time. So it's the annular ligament is not dislocated. I'm sorry, it's not torn or dislocated. It's the annular ligament. It's not the dislocation of the joint. So there's a variety of histories. It's usually a pulling theme or causing the arm to get underneath. There's no swelling or ecchymosis. And the children will hold their wrist. And the reason they're holding their wrist is not because their wrist is fractured, because they don't want you to pronate or supinate their arm. So the parents are always worried about the wrist. If the kid has a wrist fracture and they're not grabbing their wrist, it's going to hurt like heck. Okay? So here's a little girl. Smart little girl holding keys with the University of Pittsburgh logo there, okay? And you can see there's no swelling or anything, and we can either do the hyperpronation as we talked. That's even when she was 4, as you can see, from thumb up to thumb down, or you can do alternatively the method that we use for many years. You want to again make sure they're not tender on their clavicle, make sure they're not tender on their distal humerus or the distal radius. Then pretend like you're shaking the hand, fully supinate the arm, and then flex the arm, and that pops it in, and then she's using her arm correctly. And to prove it to the parents, I always do a parachute reflex, which the child can't overthink after 9 months of age. And you have to warn them about the future. Make sure they're holding their forearm when they're walking along, not holding their hand. And we've seen that before. This is something you probably didn't know for the board question and for just looking at films. Here is a fracture. You're going to say, oh my gosh, it's a fracture of the proximal ulna. No problem. However, if you got to look closely, you always want to look at the radius. The radius should be pointing to the ulna. This is dislocated radius, so this is a Montagious fracture. Dislocation of the radius with a proximal ulnar fracture is a Montagia fracture. This needs reduction under sedation. Okay, this is not just casted and sent home. This is not just splinted, and we'll see you in a few days. Okay, so splinting techniques, you want to split the joint above and below. You want to make sure there's no compartment syndrome, especially if you're dealing with a tibia. You may want to admit them, or you may want to keep them elevated. Below age 8 or 9, you got to avoid crutch use. We try and send kids below that age with walkers. And anytime there's increased pain after casting, our orthopedic colleagues almost always bivalve the cast or take it off to make sure there's not a compartment syndrome. Very important. So which of these fractures is suspicious of non-accidental trauma? This is sort of a review of what Dr. Walsh just did, but we think it's so important we're going to review it. A spiral diaphyseal humerus fracture, a 10-month-old male, a corner chip fracture of the distal femur in a 14-month-old female, a posterior rib fracture in an 11-month-old who fell inside the crib. None of the above or all of the above. I hope you all get this one right. Dr. Walsh will be proud of you. And that's me. A couple weeks ago, I thought I was going to Heinz Field, but I wound up at the Roman Coliseum. Okay. And the answer is all of them are important. Metaphyseal, this is an example of a metaphyseal chip or corner bucket handle fracture when people take the lower extremity and they violently twist it back and forth. And we see that, unfortunately, all too commonly. Unexplained spiral diaphyseal fractures. Here's one in a small infant, diaphysis of the femur. Here's one in the humerus. The typical story they always give is he was falling off the couch and I grabbed him by the arm. No, that doesn't occur. This is from violent twisting. Spiral diaphyseal fractures are from violent twisting, okay? Posterior rib fractures. Here's another example before we move on to that. Here is corner chip fractures that have been there for a while. Here's already periosteal elevation. They've been there for quite some time. That didn't happen yesterday or the day before. That happened a couple weeks ago. Okay, here is a metaphyseal chip fracture in the humerus. You can see that's from violent twisting. Whoops, wrong one. Here's a 6-week-old child who they gave a story that we were pulling him out of the crib, but we knew that not to be the case. And here you have a spiral diaphyseal unexplained fracture and a 6-week-old infant. So this was non-accidental trauma, child abuse, child maltreatment, whatever you want to call it. And unfortunately, at Children's in Pittsburgh, I'm sure it's the same in all around the country, we see way too many. There's almost one case every other day or every day of suspected child neglect and abuse. It's really rampant in the United States anymore. Multiple fractures. Here's a fracture. Here's a fracture. Rib fractures are certainly not from CPR. They are very rare in children, okay? Fractures in different stages. Here's multiple linear fractures in the skull. You can see the CT scan. This is a fracture. They're not suture lines. And here's this child, unfortunately, had multiple fractures. Here's one, and here's one there. So again, there's just a summary of misses, things to remember for your test and everything. Buccal fractures, any sharp, sudden angulation, you're going to see, especially on the lateral view, is a buccal fracture. Growth plate, anytime there's pain and swelling at the growth area, that's a growth plate injury till proven otherwise. Always look for metaphyseal chips, which would signify a Salter II fracture. Avulsion fractures, just sometimes you'll see them on one view, you may not see them on the other view. And spiral fractures, know that you can see on the anterior tibia, you're going to see nutrient arteries, but again, unexplained spiral fractures in humeruses, in tibias, are always want to think about non-accidental trauma, but kids can have toddler fractures if they get their foot caught and they get a twisting or rotational motion. So again, 2 final rules: when there's pain and swelling at a joint or metaphysis, splint the area. Make sure it's followed up with one of your colleagues, and always keep non-accidental trauma in mind with unexplained fractures or kids and children less than 3 to 40 years of age. I must say that Dr. Sabella has been a great friend of mine. He and his wife were wonderful, wonderful residents of mine back in the 1980s. But I have to always keep reminding him of something. He's very bright, and he's the head of infectious disease. But I always have to keep reminding him of one thing: you'll never see this in Cleveland, doctor. You only see this in Pittsburgh. Okay. Okay. Those are 6 Super Bowls, in case you want, and we explain that to you. Okay. Those are 6 Super Bowl trophies. Okay. Thank you very much. Good luck on your boards.